Processing University presents Issues and Challenges in Sterile Processing, a podcast conversation. This episode is Instrument Inspection. Are you inspecting right? I'm Jason Marosi, Senior Educator.
And I'm Nancy Chobin, the president of Sterile Processing University.
Okie dokie, Nancy. Here we are again. Instrument inspection. Early in my career, I never heard much about bioburden or this had tissue in it, or suction was clogged, or there's bone in this. But I tell you, in the last 15 years, it's an everyday thing.
Yes. Yep. And there's a number of reasons for it, Jason. None of them should happen. The first one is education. What type of training did people get? Was the training documented? If someone repeatedly has, say, a suction that's blocked, and you gave them training, and you even did a competency assessment, which wouldn't be a bad idea to include that in your annual competencies if that's one of the problems you're having, then you would be justified in documentation of corrective action. Now, Jason, I've spoken to you twice already. You've been in service. You gave a return demonstration, and yet you continue to have suctions that are blocked. This is unacceptable. So that's the first thing, is education. The second thing is, do we have the equipment? Is a special piece of equipment needed in order to do the testing, like a boroscope? How many people don't have the TheraBand to test the scissors that they're sharp? I mean, there's nothing worse than giving a surgeon a scissor that won't cut. Hello.
Yeah. Been there.
And and the third thing is, are people, do you have enough staff so people have the time to inspect them? If you get a whole handful of instruments, that's not how you inspect them. Do you have the training to show the type of inspections that are needed for each type of instrument? Do you have enough, as I said, enough staff to give them the time to do it? Do you have enough time to do the inspection, or you're being rushed because maybe you don't have enough instruments? They go, we need that set, we need that set, we need that set. So we can't shortcut on the cleaning. So where are we going to shortcut? On the inspection.
Yeah, there's an increase in it, but I do know there's a big change with the operating room in the last probably 15 years too, where when I first became a surgical tech in the mid 90s, you really didn't look at your tray like they look at it today. They really now, which is fantastic, the operating room staff really almost look at every instrument now when they're counting and they're putting it on their field. When I would say years ago, you just counted, you didn't really inspect them. It can get out of hand. They start questioning every little thing in this wear and tear. That's bioburden. They still need to learn the difference between foreign objects, bioburden, or just damage when they write their incident reports. It's good to see that they've really stepped up to look at the instruments that way.
Part of the problem is the operating room does have the ultimate responsibility to make sure that they don't bring anything to the sterile field that is not indeed clean and therefore sterile. Because once you contaminate the field, now you have to tear everything down and start all over again, which is going to delay the case tremendously. Unfortunately, sometimes the patient's already under anesthesia when they do it. Now, what do? You can't keep the patient under anesthesia while we do another whole setup, and it presents really serious issues. And there's a responsibility on both sides. Our responsibility in sterile processing, and I've said this repeatedly, is to provide clean, functional, complete, and sterile instrument sets. There should be no surprises. If you do have an instrument that is missing, you're going to have a label on the outside to notify the operating room and then let them know, because if it's a one of a kind, they're going to have to order another one. If it is broken, you have to notify them that it's going out for repair. There has to be good communication. We don't know the criticality of that item. So if we don't let the OR know, and then all of a sudden they're looking for it, now it becomes a big blow up, because they have the patient in the room, maybe on the table, and now we don't have what we need. So we recognize that, instruments may break, instruments may be missing, instruments may have bioburden. In my opinion, it is inexcusable to send an instrument to the operating room that is not ready for surgery. We're supposed to be providing sterile product. When we open something from an outside vendor, like from Baxter or Bard, we never question if it's safe to use.
Uh-huh.
But, once the OR's been burned a couple of times, you've lost credibility with them. And once you've lost credibility, it takes a very long time to get that credibility back. They're the ones that have to face the surgeon. They're the ones that have to hear the complaints from the surgeon. They don't like it, and I don't blame them.
You'll see how you can walk into a sterile processing lounge and hear a technician arguing on the phone with somebody that didn't do their phone order, their lunch order right.
Yeah.
Delivered. They don't realize that that's the same service you're giving when you're having dirty instruments.
Exactly. The ramifications are a lot more severe. I always say to people, if you go to McDonald's and you leave a pickle off a hamburger, all right, big deal. You wanted the pickle, you didn't get it. Uh-huh. But it's a total different animal when you're in the operating room.
Yeah. I was said to me many years ago in the operating room, the most cost of deaths in surgery are due to overexposure of anesthesia. And, again, instrument mess ups, bioburden, forgot something, that causes delays and causes the patient to be on. Because as you were saying, when there is a dirty instrument and they have to redo the field, they do leave the patient asleep, but you're expected to do it and reopen and recount really fast.
But this is why it's so important that we recognize our impact on the operating room and ultimately the patient. And they're depending on us. When Sterile Processing took over the responsibility in the late 60s, early 70s, the operating room was visibly upset because they've lost control. When the instruments were in the OR, they knew what they had. They could control how they were cleaned. We don't know about that. They usually flashed everything all day long, but they were in control. Once they started coming down to sterile processing, they lost that control. And so now they're very vulnerable, and nobody wants to be in that position. Now, conversely, we're in the same boat. If you go and schedule 6 cases back to back, and you know that you only have 2 sets of instruments, that's going to be a problem for us. And, give us a heads up and say, look, we're going to have 6 cases. Can you turn these 2 around, quickly because it's the same surgeon? Yeah, we'll prioritize that first one. And what they should do is when they start to close, not wait for them to finish. When they start to close, get those instruments down to sterile so they can start working on them to give us a chance to put them through the whole process. There's got to be a collaboration and cooperation between the 2 areas.
Yep. It's funny what you're just saying about the scheduling. Years ago, I worked with somebody who was a surgical tech that I can't remember exactly, but they couldn't do a surgical tech job no more. So they got replaced into the scheduling department. Tell you, once we had a surgical tech in that room, we had flawless surgery schedule issues. Yeah. Because they knew the instruments. It was insanely how organized we were and how our turnovers changed, everything.
Instrument inspection is an important part of what we do. If you went, here's a good example. How often have you gone to a restaurant or a diner and you look down at the silverware? That's the first thing I do, silverware and glass. If I see a lipstick mark on the glass, I'm not happy. Yes. If I see food and debris on the silverware, I'm very unhappy. And I'll call the maitre d' over and say, excuse me, I don't drink from glasses that haven't been properly cleaned, nor do I use utensils that haven't been properly cleaned. They're usually mortified, but the same thing happened. Who cleaned them? And then who set the table? You didn't look. Sometimes they're wrapped up in a napkin, but still somebody had to handle them to put them in the napkin. That would be a perfect example. It's no different in the operating room, only the consequences are a lot different. They just bring you a new glass, or they bring you a new set of silverware. They don't have that availability in the operating room to do that all the time.
Very limited sometimes to what we can have.
Yeah.
Now, many will ask, where does it go wrong? First, when it comes to inspection, we all know that it's wrong when it decontaminates where it goes wrong, but when it's inspection part, where does it go wrong? And I would say in 2026, it's this guy here, your cell phone. This is what makes it go wrong. I have seen lately so many techs that this is on the desk, and as they're inspecting, I could see them just going like that, the phone, putting it down, inspecting, and picking it up. Hospitals are starting to support having cell phones in the work area, and I think it's very distractive and does not help the instrument inspection part.
Well, first of all, the current AMI standard is you need to have a policy on the use of personal electronic devices. Whether they'll become more strict or not, I don't know. But there's a couple problems with that scenario. Number one, you're distracted. If you're being distracted by the phone, you're not paying attention to your work. And if you're being distracted by the phone, that's non-productive time. We're not getting the work done. As a parent, many years ago, yeah, you would get a phone call, if there was a problem with your child care or what have you. And I'm not saying that there shouldn't be a matter of notification, but in my opinion, it should say that cell phone use is for emergency calls only, and it's up to the employee to enforce that with their family. This isn't social media time. And the second thing is, we've learned that every time you change your activity when you're doing instruments, you should wash your hands or put on clean gloves. Are they doing that? They're probably going through a box of gloves with one set if they're getting all those phone calls.
Yeah,
so come on, let's quit playing and call it what it is.
And I tell you, a lot of managers should be aware with that on the table. If you go on social media, there's a lot of photos of people at work doing SPD work those photos should not be online.
Well, there usually are policies preventing you from taking pictures within the facility, because that becomes a public relations issue and a proprietary issue for the hospital. So they have to be very, very careful. And facilities that do not have a policy on the use of personal electronic devices need to know that this is a big issue and they need to address it.
I mean, the first things first, a lot of people do not know what to do when they grab their tray. Should they take one piece out one by one? Should they kind of dunk it? Should they have a towel on their workspace, non-linting towel, or should they put a piece of wrap?
Well, no, some people think that you shouldn't put your instruments right on a stainless steel table. I disagree, because it's very easy to clean stainless steel. But if you want to have something, there are mats that are specifically designed, and you follow the IFUs for cleaning them and changing them and what have you. But the first thing you do, you don't dump the entire set onto the table, which I still see happening. That is a great way to damage your instruments. They should be taken out one or two at a time and then do the inspection for them. For example, if it's a hinged instrument, you're going to look to see that the box locks is clean. 70 to 80% of the time, I find debris in the box locks. What does that tell me? They never opened these completely for cleaning. So you have a buildup. You're the inspector, Inspector 12. If you see that, it goes back to decontam. And you tell them this has to be recleaned. Then you're going to look to see if there's a crack in the box locks, because that's the weakest part of the instrument. If that is a hemostat, and it fails when it's on a vessel, you could have the patient bleed to death. So that's an important thing. If the instrument, say, for example, it has serrations on the jaws, are the serrations all clean? If it's supposed to have teeth, how many teeth? Are they both there? And you need to do this under magnification. When you do that, you're not going to have eye strain. Doing this all day without magnification, your eyes aren't going to get tired, okay? So I should have at least 5 times magnification. And every instrument needs to go through that process. You need to check if it's a ratcheted instrument that the ratchet's going to hold. If it's a needle holder, is it going to hold the needle? There are specific tests for each type of instrument. And the staff needs to know that, and they need to do it. Now, again, if there's any problem with any of them and it is a cleaning problem, then it just goes back to decontam. We had a set that made its way through, and the tip of one of the jaws was missing. And it was never noticed. They noticed it up in labor and delivery, or they would have thought that they left it in the patient in the C-section set. So this is why the inspection is so important, not just for the cleanliness, but is it functioning correctly? I, in one of my hospitals many years ago, I'll never forget, they needed a Balfour retractor for surgery, which we sent them. They call me and say, Balfour's missing a screw. We sent another Balfour open. That was missing a blade. We sent another Balfour open. 5 Balfour retractors. Every one that we had, there was something wrong with them. They finally had a piece together. I was mortified. I was absolutely mortified. And you could believe there was intensive in-servicing after that. Something like a little wing nut could stop the whole surgery because they couldn't attach the blade. So it's really important that the staff be in service, what the instrument is and how it's used and how critical it is. When it comes to your sharp instruments, there's all different tests. And there are companies that make instruments that have instrument inspection kits. For example, they have materials, I said, to check the sharpness for your scissors. There's 2 different thicknesses. They have things to check if you have a rongeur to see if the cup is going to make a cut on the bone. There's all different tests. You need to have those materials. You cannot provide instruments if you don't have all of the equipment to test them appropriately. And then the staff needs to do it every single time, not just when somebody's standing over me or when I have the time.
Yes.
If you're rushed, then why bother?
I used to do rounds, and I used to laugh to myself when I would come in, and I would see, as soon as I walked in, I would see all the lights go like this. And it's like, oh, now you want to use them because I'm in the room.
Well, I could tell because I'd go over and I'd touch the lamp and it'd be ice cold. I said, who are you kidding? Another one that's really critical is the installation on laparoscopic instruments.
Yes.
Now, it's finally been addressed by Amy in the amendment in 2020, but there's still facilities that aren't doing it. And it includes your LEAP instruments. Nobody was doing the LEAP instruments. And those things, because of the safety factor, I mean, it's all a safety factor, but because of the burn factor, that should be documented. You tested each and every instrument and that they passed the inspections. This is really critical that they do the inspection. There is no excuse in a court of law. If you said to me, I didn't have time to do that because the OR needed that set. And what about the patient? Did the patient know that? Wouldn't the patient have the right to know that that set wasn't properly inspected and tested? No, the patient doesn't know. And so it's presented to the jury that they don't really have a good standard of care for their patients. They do it if they feel like it. They do it if they don't. That's how it's presented. And I don't think anybody wants to be presented that way in any manner, shape, or form. But that's the message that you're sending.
And I think time is a big issue. I see a lot of people and a lot of managers, and especially when they're talking with administration and the OR directors that usually are the director of sterile processing about productivity and time. Each tray, like some trays that nowadays, because it gets out of hand, if you don't have a good handle of how many instruments are going in your tray, some of these techs have to inspect 100 and something instruments.
Well, there's a couple issues here. Number one, I'm a firm believer that just like your IFUs have to be updated all the time, you should be updating your instrument sets. Because how often you look at a set and you say, oh, we don't need 16 clamps anymore. We could do with 8. Okay, Let's take the 8 off. What are we leaving them there for? It's more work for you to count. It's more work for us as well. So we both win if we do that. But people, well, we don't have the time. Well, if you don't make the time, then you're going to have to make the time to do the counting. You can't have it both ways. And you don't have to do them all at once. If you talk to the OR staff, and it has to start with them, and say, give me 10 trays that you feel have too many instruments on, that repeatedly, they're on the back table, you don't need them. Then we're going to start with those trays. And sometimes your instrument company, if you have a prime vendor agreement, they will actually send in people to help you with that.
Yeah.
They'll help you, decrease, and then you can use those instruments either as backup, or you could use them to make new sets. There is a benefit to that, to make sure that you have just what you need, on the set. We really have to work together to get the job done. And just talking about it and making excuses for it doesn't solve the problem. Now, when it comes to the productivity, my question to people is, well, where did you come up with your productivity standards?
Uh-huh.
Well, I read it in an article. Well, who wrote the article? Did they ever work in SPD? Do they know anything about the things that we do? They're not aware of all the things. When you make a list, many SPDs are doing code carts, intubation bins, patient care equipment, minimal supply distribution. There may be specialty items that they're stocking. They're doing loaned instruments. They're doing instruments for doctors' offices, for off-site clinics. All of these things are not considered when these experts come in to look at productivity. They do how many cases in the operating room and how many births in labor and delivery. None of that is our productivity.
Yes.
Because a case is not a case in the operating room. How can you compare a total hip case with a tonsillectomy? One tray or two trays versus 30 trays. And there's a lot more on those sets than there is on a TNA set. So you have to look at the complexity of the set. And they don't even consider, as I mentioned, loaners, which in many cases could be 20 to 25% of your total volume. And it's not factored into productivity.
And to me, the loaners have more hidden departments in their instruments that takes a lot longer to inspect.
There are productivity standards that were developed by Amy and published, and that's what people should be following. It covers the instruments from the time they're picked up to the time they get put on the shelf. And it covers the time to pick them up, to clean them, and they're broken down into the complexity. So obviously it's not going to take as long to clean, say, for example, an eye set, even though eyes are done for the most part today in surgery centers. But if you have a smaller procedure, it's going to take a lot less time to clean it as it would to do a case for a total hip or a total knee or spine. So that's all factored in. You have between 15 minutes, 25 minutes, 45 minutes, 75 minutes. This all factors in special processing. For example, if you have CJD precautions because of prions, those trays are going to take an extended amount of time because you have to first sterilize them unwrapped and then bring them out and then sterilize them wrapped. If you use those numbers, you will see what your productivity should be. And at one major facility, and you helped me with that, Jason, we were able to justify 6 additional FTEs based on the productivity that was done using the analysis from Amy. So when people come in and start telling you, you got to lose people, what are they basing it on? They have to base it on what you actually do, not the number of patient days, which is nursing's productivity, not the number of OR cases, because that's OR's productivity. And what they need to really understand is a case is not a case. One case to another case could be hours of difference in terms of processing.
Correct. Absolutely. Like even we said that some of the basic surgeries, like a gallbladder, not everyone comes out the same. Some comes out with, sometimes they have to open. There's more instruments. Sometimes there's not. You're 100% on target with that. You really need to use the national standards recommendations for.
Well, the reason why this has really been a buzzword for me was because in my own hospital a number of years ago, before I retired, we had a consulting company come in and they used their productivity analysis and said that the SPD at the one hospital they were at had too many employees based on their data. And so 6 people lost their job overnight.
Oh,
and it absolutely crippled that department. It was terrible what they went through. And it took, I don't know how many years before we were able to get the justification to bring not only those jobs back, but add additional FTEs. So I tell people, don't wait for the bean counters to come knocking on your door. Get your productivity stats together now and keep up with them so you're prepared when the time comes. I also see this with policies, Jason. People don't have a policy for everything. And then all of a sudden they have a problem. Their washers go down and there's a water main break and they can't do the instruments. What do I do now? Well, where's your policy? Well, we don't have one. You have to have a policy for every eventuality. Hopefully you'll never need it. But the time to worry about it is not when it happens, because now you're in crisis mode. What do we do? What do we follow? Where can I get the information? That's crazy.
Yeah, I've had that with cart washers. They break, and what are we going to do? Well, what's our policy? There is no policy. Well, you can't just start wiping it down whatever you feel like.
Yeah, we had a hospital that couldn't get a cart washer, and they did have issues with what they were doing with their instruments at the end of the cases. We did a process where we did have some metal carts. They were, double door, horizontal, so you had one shelf in there, so you could put stuff on both shelves. What we did was we had them. Some of the trays were wrapped and some of them were in rigid containers. The wrapped trays we put in a tote bin on the cart. The rigid containers we put in a red bag on the cart. And we had those signs that I talk about where we downloaded the OSHA symbol for biohazard, printed it on orange tape, orange paper, and every OR room had those sheets in there. So they would put the instruments on the cart, put the sign on the outside. When it went to decontam, they would wipe the cart down with a disinfectant because it was made of metal. We didn't have a problem because there was nothing inside. There was no spillage because everything was confined and contained. So the containers that we used were disinfected according to the IFU. So there was no problem. So you've got to have, a policy for everything. And then when something happens, you're ready for it. And if not, you're probably going to make a mistake, and that's the worst thing that can happen when you already have a problem and then you don't handle it correctly.
So for inspection, basically what we're looking for is bioburden, stains, rust, water spots, tape residue, detergent residue.
Yeah, let's talk about tape, because that's another one that Joint Commission is really on a roll with. And we have some pictures that we're going to show a little bit later. I actually was doing an audit, which I did all the time. And there were two instruments. When I picked them up, the tape actually fell off of the instrument. It was so dehydrated. Now, could you imagine if that happened in the operating room and it fell inside the patient?
Oh, my God. Yeah.
Because first of all, that tape, any adhesive, we know that blood and microorganisms adhere there and we can't get them off. So that's a no-no. We would have had a foreign body in the patient. But it's inexcusable. I also, when I do find a defect, I would not only discuss it with the employee on a one-to-one, but then we would have an in-service. I would take pictures, because I'm not going to point a finger to a person and embarrass them in front of everybody, but I would take the picture. And I have a picture of a laparoscopic suction that I had put a extra long Q-tip, so to speak, through it. And I got dried blood out of it. And I used that in an in-service. I said, how would you like to have this in your belly? And, everybody's going, no. I said, well, this was an instrument that you did, and it would have wound up in somebody's belly.
Yeah.
So they need to understand the ramifications of when they don't do their job. Like you said, the person in decontam should have cleaned it correctly and tested it there. But it was bad enough that they didn't test it. The problem is, if you tested it on the clean side, we've now contaminated the clean side and ourselves, which is an OSHA violation. I'm a firm believer that all the cleaning verifications should be done in decontam, so we don't have to worry about it on the clean side. These are the things that you have to do. There is no excuse for an instrument to go to the operating room that is not clean, functional, complete, meaning if it's multi-part, and sterile.
Now, water spots is on this list, and that's a very sketchy topic, because a lot of people will move forward with using instruments with water spots, and then some other people will not.
Well, technically, a water spot is just due to water, okay? It tells you there's a problem with your water, because there wouldn't be water spots. It could be there's a problem with your steam. There's any number of reasons why you could have it, but the bottom line is it doesn't belong there. if we have any defect, not only on the instrument, what about on the packaging? How often on a peel pack do you see like a brown residue?
Uh-huh.
Usually that means that there was blood or body fluids in that box locks, and during the vacuum phase, it was sucked out. And now we have it staining the packaging. Anytime an instrument has any type of spotting or staining, we should not use it because we're not sure what it is. If we're not sure, how could we defend that in a court of law? We can't. And I know people keep saying, you keep saying in a court of law, you don't know when it's going to happen.
Yep.
So you know that it doesn't belong there. Why are we allowing it to happen? Let's get our committee together, our water quality committee, and say, hey, what's going on here? Get your sterilizer manufacturer, your engineering person, your water quality person, your water system person. Get everybody in the room and say, okay, we're going to find the problem and get it done.
Yeah, because I can even the tray liners, white ones, they have a lot of stains on them. And again, people don't, use a tray, not use the tray.
Well, no, they switch tray liners to a different color.
Yes, that's usually, just don't get white. I've been told that many, many times.
I know, and I understand the frustration, but people don't understand. I've used this example because it happened to me where I was having positive biologicals, and the first thing I was told was switch your BI. And I said, no, it's doing its job. It's telling us we have a problem. I know it's inconvenient for the operating room because we keep getting, today you've got the quick BIs, but back then it was 48 hours. So, 48 hours you get a positive, they already used the device. So, but you have to understand that there's a rationale for everything, and we have to do what's right. If we have something that's telling us it's wrong, don't make excuses. You have to do the work to figure out what's wrong and document the entire step so that you know that you did what you were supposed to do.
And I'm a firm believer too, if you have 4 or 5 people at a workstation and they're all the ones that are inspecting instruments, don't have them get the phone, get the cart washers. Let them just sit and inspect. Designate somebody to do that, because if they have to get up, they're going to lose track and they're not paying attention fully.
Yeah, I learned that a long time ago. One day we were really short of help, and I take full ownership for this. And I was helping out doing the autoclaving. And so I put a load in, and I was answering the phone so that they could get the work done. And somebody took the load out and say, who was the genius that put the lock control label gun on the cart? Guilty as charged. Again, I'm being distracted by the phone, and I forgot about it, and it went in. We could laugh about it. Yes, they cost money, but at least it was a patient care thing that, delayed care. I'm a firm believer that every day there should be a person who handles the phone. Yes. And that can rotate through, and it has to be somebody that knows the equipment, knows the instruments, so that they can respond to the operating room. Furthermore, when I made the assignments, when that person went on break or lunch, someone was assigned to cover the phone.
Yep.
So maybe they weren't on all day. And it really makes the department run so much better. As a matter of fact, because you worked in a facility, when you have an off-site facility,
yes,
they don't have people interrupted with buzzers and bells and phones. That's all done in an office.
Yep.
That's why, their productivity and their accuracy is much better because they don't have all the distractions. And that's what
I'll tell you, it was an incredible experience to wash, clean, autoclave without an operating room, without hospital units, with just yourself in a factory. Yeah. Incredible.
Yeah.
The amount of work you can get done is so good.
Well, with the buzzers going off and the phone ringing and emergencies, you don't have any of that off site. You're able to get all the work done. But that's another whole nother story, about offsite processing.
That's another podcast.
Yeah, and it is becoming more popular for those exact reasons, Jason.
Yes.
It's really important that we make sure that people know what to do and they have the time to do it. And we don't have all these interruptions. Mitigate them as much as you can. Because again, This work requires a lot of attention to detail. And
Yeah.
when I see somebody say, well, I did 35 trays today. Really? Let's look at what type of trays you did. And,
Uh-huh.
I may do some audits on them. You may be a superstar, but if I know that there's 75 instruments on each of those trays, and you did 75 trays or 45 trays, I have a little bit of a credibility issue. I just want to be sure that, quality, in my opinion, is much more important than quantity,
Uh-huh.
unless your quantity is going to be perfect.
Yeah.
So I'm not impressed that you did 45 trays. How many of those 45 trays were clean, were accurate? All the instruments were there. Nothing was missing or broken.
Uh-huh.
If that's the case, hey, you're number one. But
Yeah.
in many cases, because people are forced to say, you have to do this many trays. That's what our productivity is.
Uh-huh.
That's not good, because now you're forcing people to take shortcuts, because everyone's going to work at a different rate. There's some people that are more knowledgeable in the instruments as opposed to other instruments, so they could do it in less time. But as I mentioned, I like to have a combination of, the people who are going to pay a lot of attention to detail and be oriented that way, who have very few mistakes, as opposed to the superstars that get a lot of instruments done, but we have more mistakes because of their speed.
That's the other thing is like I've had some staff members that had a lot of, bioburden in their trays. And before I did my first corrective action, I did take time to study, like, are they the ones picking up the phone because nobody else wants to, or are they're the ones that are getting interrupted at their desk by the operating room, because sometimes the operating room will come into sterile processing and they already had words with certain people, so they don't want to ask that person for help. They go to the one person all the time. You
Yeah.
got to identify all that, because again, if they're inspecting, they're supposed to really just be inspecting.
Unfortunately, Jason, I've seen where, depending on how the tables are set up, we're talking, what'd you do last night? Yeah, I went here, I
Yes.
went there. These conversations going on, or maybe even music. You talk about the cell phones, they're playing songs and music, and I don't particularly like the music because it's interrupting my train of thought. These are all things that you have to look at. You have your instruments, and then you have, I could call them accessories. Although laparoscopic instruments are instruments, there's special equipment you need. It's according to the AMI standard. When you purchase an instrument, you should be purchasing any and all equipment they recommend to properly clean, disinfect, test, and sterilize the device. So right there, that's your contract. Why would you bring these instruments in without having what you need to make sure that they're being processed correctly and they're going to be safe to use when they're going to be used in the operating room? That's our responsibility. When we give the operating room an instrument that hasn't been inspected properly, even though that is the AORN standard that they're supposed to check them, it could get by them. So,
Yeah.
if we do our job, there's less of a chance that something's going to slip through the ropes in the operating room. And quite frankly, they shouldn't have to be mother hen and look over everything we do. They should be able to depend on us. And that's where I have a real problem. I really do. And I think that's where sterile processing loses a lot of credibility, not only with the operating room, but the surgeons, because they're hearing all these complaints, oh my God, we got bioburden again. It's the third time this week. And so it's no wonder that a lot of times, they have a very poor opinion of sterile processing.
I've gone to so many places where they say the doctors lost faith in sterile processing. It's so
Yeah.
sad.
Well, I told you at one facility, the doctor reported, he said, you're always talking about you don't have enough people. Every time I go down there, the radio's blasting like they're having a party. Perception is 97% of the rule, people. If you want to be treated like a professional, which we're supposed to be, a professional member of the surgical team, then you have to act like one. Party. This is not a social gathering. This is a medical device reprocessing department. and you are responsible to make sure that those items are going to be correct in every manner, shape, or form when they go to the operating room.
Yeah.
I can't believe that anybody who worked in SPD who had a patient that was subjected to instrumentation that was not correct would be very happy about it. So you should consider that, and we've said this for years. Treat every instrument set as if it was going to be used on you or a member of your family.
Someone's having an operation and they only want a certain person to clean it, a certain person to inspect it. It's
Is
just
that is that fair to the patient? They don't have that knowledge.
correct. Yeah.
They're assuming that everything is going to be correct. So does
Hmm.
the surgeon. We're victims of our own problems. Now, I don't want anybody to say, gee, she's always beating down on sterile processing. No, I'm not. You'll never find a better advocate for sterile processing than I am. Just look at my bibliography and see what I've done. I am a firm believer that, we no operating room could exist without sterile processing. The surgeons can't do the instruments. The nurses can't do the instruments. They might know them, but they don't know how to clean them and do all the things that we have to do or operate the equipment that we have to operate in order to clean them and test them. If we're going to be part of that team, then we have to perform up to their expectations. Don't, then we have failed. And I don't want to see people failing. I don't want to see, go into facilities where people are told, oh gosh, we got the worst SPD in the world. That bothers me. It
Yeah.
pains me when I hear that. And so, we've got to fix this because nobody, in my opinion, comes into work in the morning and says, I'm going to see how I could mess up the OR today.
Yeah.
You
But
know,
I do think there's which is not a sterile processing problem. It's a country problem in the sense of the economy is so bad right now, and it really economy's not been good for a very very long time. But I think the average tech now is more concerned about money than it used to be. Just having the job was good enough, and you felt like you were contributing to society. But I think people are in such financial stress now. It's more about the money than it is about what I do for a living.
I think it goes a step further, Jason. And again, when I ran a department, I made sure that every candidate that came in, I read the job description with them. I gave them a tour. I wanted them to understand what they were getting into because all they see is, oh, I'm going to wear a scrub suit. I'm going to be going up to the operating room. Everybody's going to really be impressed with that, as they should be. However, if you don't do that and they come in and going, hey, you're paying me $10 an hour and I have to do this.
Uh-huh.
And so they get disgusted and it starts reflecting in their work.
Yep.
And then before you know it, you wind up losing them. And I know people are pressured that they need to have the positions filled, but you get what you pay for. If you're not going to take the time to train people and make them successful, then you're going to wind up with a constant problem of people leaving and having to train, and you get into that cycle and you never get out of it. We want to encourage people to stay, that we can promote them, that they can grow in the department and share their knowledge with new people. That's what we need to do. Too often you just see a revolving door. We can't keep people no matter what we do. And
Yep.
even when they increase the salary, well, that tells you something else is wrong.
4 years ago, I was in Pennsylvania, intern management at that time. I had like, I don't know, 8 positions opened, 4 workers, 4 travelers, and plus I had still 8 more positions to fill. It was insane. And they wanted to become a level 1 trauma center to top it off at the same time. And I couldn't even get anybody to work in sterile processing. Why? But when I sat down with everybody who lived in the town who worked at, a lot of them worked at Walmart, a lot of them worked at McDonald's, all the fast food restaurants. Everything was, when I got to pay, are you kidding me? I'm making more of that at Walmart. I'm
Yep.
making more of that at McDonald's. And
Yep.
they would turn down the job in the interview.
Yep.
And they
Yep.
would have gotten it. They would have gotten the job. We needed to train, we needed to hire.
And the sad thing is, what you'll hear from HR is, well, we did a salary survey and this is what the other hospitals are paying. Yeah, but they're not here. And if we can't attract people, then we have to do something to get them in here. And
Mhm.
so people very often are forced to settle, for lack of a better word, of somebody that they know is not going to work out, but at least it's a pair of hands, according to them.
Yes.
No, a pair of hands is not an excuse, because
Mhm.
when you just have a pair of hands, it's going to reflect in the work. You're not going to put in the time to train them because you know they're leaving. And so they wind up doing menial things like maybe, oh, we'll do a bunch of peel packs. Not that that's menial, but you try and
Sure.
give them something like that. Or even worse scenario, they put them in decontam because nobody wants to work there. So it is a major, major issue. I still say the root cause, instrument inspection errors, meaning that why we have defects, is due to lack of proper training, continuing education, and competency assessments. People are well trained, you're not going to have these problems. You have to make the time, you have to make that investment. If you don't put the knowledge in, you're not going to get the knowledge out.
Well, an employee to me is only as good as its leadership.
Oh, absolutely.
We said it earlier on this podcast. If somebody's having problems, again, corrective action is not necessarily the first step. Education should be your first step. You
Yeah.
know, who trained this person? How long have they been there? What's their workload like? Do they have any problems personally? Sometimes, I mean, you have to be careful on how you ask, but sometimes you find that somebody has a dying relative at home or close by, or have childcare issues. You want to try to work with your staff.
Well, sometimes, and we talked about this in other podcasts, you may be lucky enough to have a dedicated SPD educator, but in
Uh-huh.
most cases you don't. Then it does fall on the manager. There were many things in my career that I never heard of, that I never saw. It was new technology. I remember when they came out with laparoscopic instruments. That's how far back I go. And
Yeah.
they came in, they did an in-service. We didn't have cell phones back then, but we got like a 15-minute in service. And then after he left, I couldn't put him back together again. And I forgot to take them apart. And it was a Friday. And of course, they were going to use them on Monday. And I couldn't reach the rep because I guess Friday after 3 o'clock, he's not available. So I had to call the operating room and have them come down. And I called audiovisual because we did have a good audiovisual department. I said, would you please send somebody up here so we can have a videotape of this so we have it available for everybody. So I wanted to learn so that I could continue to support the staff. And my staff appreciated that. I kept them up on everything. When I would go to an Amy meeting and a staff meeting, I would update them on what we were looking at, maybe something I learned, maybe an article that I read. And they would always say to me, and I told them to call me Nancy. I didn't like to be called by Mrs. I said, no, you call me Nancy. I'm one of you. And say, Nancy, you're very, very strict, but you're very, very fair. And we love the way that we're learning from you. That's what they want. They want that knowledge. They thirst for it.
Follow your policies. You got to treat everybody fair. You got to make sure, again, following manufacturer's instructions.
Oh, yeah, absolutely. Absolutely. And even the equipment you need, you may need a special brush. You may need a special piece of equipment to test it. All of those things, that's why I say again and again, before you buy anything, get the IFUs so that you know everything that you need, whether it be a detergent, a brush, a piece of cleaning equipment, a piece of testing equipment, whatever you need, you purchase it at the time. Because once that gets in there, they want to use it.
Yes.
And they're not going to know, oh, wait a minute, I didn't order this. They don't want to know. We booked the case for next week. So that is your responsibility.
Sometimes the next day.
You're right.
Get it in there.
Generous.
I would be surprised that afternoon nowadays. You should have yearly competencies. You should have competencies on new people after 90 days. Don't be afraid to fail somebody, even though they are your loved worker, or your greatest worker. If they don't know it, you can fail them. You don't have to reprimand them. You have to educate them and revisit it 30 days later. It's very simple.
And also, if you have a piece of equipment or instrumentation that does have multiple steps and is more sophisticated, you could do up a competency sheet and do it for on the employees before they start processing it. So
Yeah.
that is what we call special competency under special equipment or special instrumentation, because it's that important, because it's that different. I mean, you don't need it on a basic set or something like that. But when something falls outside of that purview of your general inspection and testing, you need to have some competencies on that. And sometimes the company will already have them and will give them to you.
Yeah, yeah. So this company sometimes can provide really good ones.
Yeah.
One of the other things is, and this happens to me because I've had that career where I kind of moved around a lot, and being the manager, I come in and I ask a question, and it's, you don't know that? You're a manager. You should know that. No, everybody uses different instrumentation, different types of machines.
Yeah.
Never hire somebody and expect them to walk in and not to have questions or know how. Like, I've walked into places and said, "Oh, I've never used that brand cart washer. How's it used?" Like, yes, I'm the manager. Yes, I have a basic idea, but do I want to do it wrong? Do I want to skip a step? No, I want to know how it's, well, one, I also want to know how you are doing it, so I can, evaluate that, plus learn something that I might not know.
Yeah, and that's important. And we talked about this when we talked about hiring. When you hire somebody, either a temp from an agency or someone who comes to you with experience, don't assume.
Yeah.
Maybe they use company ABC washers or ABC Sonics. Make sure you have a competency check sheet that you should have developed when you got the equipment, and use it just to be sure that they're comfortable using it. Also, don't assume that they're going to know what your policies are. Now, I don't believe in handing somebody the policy manual on the first day, because it's not going to make sense to them. But certainly, if they're going to be assigned to decontam, here's our decontam policy, and go over it with them. Don't put it in front of them and expect them to read it and assume they did. No, go over it so you know that you went over everything with them, so that if they're not following it, they go, "What happened? We went over this. Why are you not following it?"
I mean, you're right, because a lot of people just put them in the break room, throw the policies down, and say, "If you have a question, let me know."
Exactly.
You have to give some time to your new employees, and especially if you're having somebody that's having inspection issues, it doesn't hurt to meet with them weekly to get some kind of, or sit with them at the table, and check how they're inspecting, or bring them into the office if you want privacy, and ask them, how's it going? Are you getting the time that you need to inspect? Are you being overrushed? Because inspection is the key to making. I mean, doing it right in decontam is always going to be number one, but that inspection, if it's not right, it's gonna fail. You're the second shot.
Well, in your orientation guide, you should have a list of every single task. Who did the in-servicing, or who did the education, and when the person gave a return demonstration. So you should have that documented. If I showed you this is how you test the laparoscopic instruments, and the instruments are not being tested correctly, I'm going to come back and say, wait a minute, when I trained you, you gave me a satisfactory return demonstration. Why are you not doing it correctly now? There's no excuse. You got to put the time in. People say, "Oh, you know how much time that'll take?" Yes, but if you don't do it then you can't come back later. You have to be sure that once you've checked them off on laparoscopic instruments, that they're going to do it correctly. And if they don't, then you and I are going to have a very serious conversation why you changed what you were doing correctly to decide you're not doing it correctly.
Yep. One more quick thing before we go over your pictures here. This is an issue I think that's a lot of people have, that maybe we can shed some light on to help them. When a person giving a corrective action and the question comes up, I didn't wash it.
The person in decontam has the obligation to ensure that everything that comes onto the clean side is safe to handle. Now, say, well, I'm wearing gloves. You're wearing gloves so you don't recontaminate it, okay? That person in decontam also has to be counseled, because they created an OSHA violation. So 2 people have to be called in when you have a defect like that. Absolutely. But the issue is it should have been caught in the department.
Yes.
So as long as it was caught, that's a good thing. But they both have to be, the person who found the error is not going to be written up because they found the error. You have to go back to the person who created the error.
A lot of people, because that gets brought up a lot, because a lot of times when they find in the OR, the only person that gets reprimanded is the technician who did the inspection and not the technician who cleaned it.
Right.
And it should be everybody.
Right. Everyone who handled, if it got through, then both of them have to be disciplined. Correct.
All right. So let's get to these nice PowerPoint pictures you gave us.
Yeah, this is an interesting article that I found that really draws attention to how costly mistakes are. The average cost for an operating room per hour is $62 a minute or $3,720 per hour. Now, if your facility has 4 operating rooms, just 4, and SPD causes a delay of just 1 hour a week per OR, that's 4 hours a week times the hourly rate of $3,720 is over $14,880 in 1 week lost revenue. When you multiply that by a year, you have $773,760. Think of what we could do with that money. I'm not testing your instruments and cleaning them correctly.
The 30 years of doing this and dealing with this, nobody ever sat me down and said, this is what's costing us. I've heard about time upsetting the surgeon, about the patient care, but I've never, ever been given a financial look at it. And this is amazing.
That's why I did it. An excellent article. All right, this is that lap suction that I took a picture of and showed my staff. And this was sterile, wrapped on the shelf. Now, when I do an audit, I just arbitrarily pick things. I don't look who did it or anything. I look at what the item is and I go, if we're going to have a problem, it'll probably be with a suction. And sure enough, you'll see in that red circle, there's 2 black dots, one on each one of these swabs. And that was inside of the suction. Now, this is what I use for education. And I would tell the staff, how would you like to have that in your belly? This was one that was sent up to the operating room and ready to use on a patient. And of course, they can't see what's inside of the suction, in the operating room. So that's unacceptable. Here's one where you open it up and look at the debris in the box locks. You'll see a red arrow. But if you look at the circle, when they opened it up, some of that debris fell on the table.
Yuck.
Could you imagine that being opened up in the OR and it falls inside the patient? So this was a double failure. Not only did the person in decontam not do their job, but the person in prep and packaging didn't do their job. There's no way they could have inspected that.
Yeah.
This one we have pitting, from exposure to alkaline chemicals or saline. Pitting creates little craters on the surface of the instrument and allows blood and body fluids to get in there that are difficult to eradicate. You have to have a smooth, intact surface in order for that instrument to receive the sterilization it needs. So pitting is never acceptable. Now, we do have floor grade instruments. Sometimes they're used in the ER or places where there's high loss, and that's okay, but they're usually single use. You have to read on the instrument. If it's single use, they shouldn't be reused. You don't want to mix floor grade instruments with OR grade instruments because the floor grade, if they are reusable, have a tendency to rust much quicker, and then they're going to rust your good OR grade instruments. So they're not acceptable in the OR for that reason, plus they lack the fine detail that your OR grade instruments would have. And sometimes single-use instruments can also have an attachment on an instrument. For example, the covers on the mouth gag. So you would have to find out if they're single-use or reusable. I always recommend they be single-use because how do you track how many uses there are? This is an example of staining of instruments. And again, we've said in other podcasts that anytime an instrument does not look like it just came from the manufacturer. There's something wrong with it. We don't know what causes staining. Is it detergent? If it was detergent, it could have prevented the steam or the sterilant to make contact with all surfaces of the device. Is it something that's in the water? How do we know if it's good or bad for a patient? We don't know. So whether staining is on the instrument or the packaging, it's unacceptable and it should not be used. This was an instrument that was sterilized closed. So I opened it up because I wanted to speak to the person about it shouldn't have been sterilized closed. And look what I found. Inside the box was completely rusted out. There was no way that instrument was inspected.
That's incredible. I mean, that's so like yellow orange that.
Yeah.
Oh my God.
Here's two more defects. You'll see visible debris on both of these instruments. Now, these were noted on inspection, which is a good thing, so they could go back into decontam, but that's why that inspection is so important. Here's a cracked box box. Inside that black circle, you'll see a red arrow, and there's a very tiny crack. That is a real danger in the operating room. Your box box is the weakest part of the instrument and also the most difficult to clean. But again, if it's a hemostat that's supposed to be stopping the flow of blood, that instrument could fail and the patient could bleed to death. So when you have a crack in that box box, the blood and body fluids get in there and you can't clean them out. Yep. That is an instrument that has to go bye-bye. Can't use it. This is another one that's a big one for me. Chrome plating. Now, some instruments you have to buy chrome plating. You don't have a choice. If you can go with stainless steel, it's better because you don't have to worry about the plating coming off. But if you see in the top photo with the red X, that instrument should have been gone a long time ago. Why? We no longer have that smooth and tack surface like you see in the one on the bottom.
Yep.
And the same thing with knife handles. I see them all the time. People think, well, it's not an important instrument. That's not the point. If it's not have that smooth and tack surface, we're not achieving sterilization.
Yep.
So get rid of your chrome-plated instruments. Now, some companies claim, some repair companies, that they can replate them. And if yours will, go ahead. But otherwise, you have to remove them from your sets. They don't belong there. And here's our friend instrument marking tape. The picture on the left, you'll see one little piece is folded up. And that's because it wasn't applied properly. But where it's not adhered to the instrument is where the blood and microorganisms will congregate. On the right, that's the one I told you about when I opened it. That tape that's just to the left of the two retractors actually fell off the instrument. Could you imagine if it went into the patient? So two caveats on instrument marking tape. Number one, don't use it unless you absolutely have to. It's more work for you. Number two, if you do have to use it, limit it to maybe doctor's specialty instruments. And understand that if you do use it, you must inspect the integrity each and every time. Now, some of your instrument repair companies, if you have a contract with them and they routinely maintain your instruments, they will take over your instrument marking tape and change it as necessary. But my recommendation is don't use instrument marking tape unless it's absolutely necessary. Know how to apply it correctly and make sure that your staff knows that every single time it must be inspected. If it at least starts to pull away, you have to remove it, remove the adhesive residue, rewash the instrument, and then reapply new tape. This is the number one deficiency with Joint Commission right now in terms of instrument processing.
This definitely includes our time. This was a really good podcast. Nancy, thank you. I want to thank the listeners. Please like, subscribe, leave comments. Let us know what you need to know, what you want to learn. We'll be more than happy to discuss it with you.
Yes, thank you. I hope you found this helpful.
To receive your free CEU approved by the CBSSPD and HSPA, go to www.spdceus.com. Watch the entire podcast on the Sterile Processing University page, and then after that, you will receive a free 1-hour CEU. Thank you.
is not a boy I know who wouldn't want to date her. She is the epitome of everything that's groovy. How I'd like to take her to see a drive-in movie. Oh, Daphne Blake, sweeter than a milkshake. She's the icing on the cake. I wanna see her. Whoa, whoa, whoa. Now there's a place in